HIPcast is brought to you by Enterprise Social Record.
Welcome, everybody, to a crossover event for the HIPcast channel. Pretty excited to be here with Seth and with Kristen and with Mississippi, but also known as Lorie.
Yes.
Today we're going to just do a round robin in a sense. Seth is kind of going to be our host or our MC of the day, and he's going to be firing some questions at us that came from, if ask a healthcare professional. So he's got some questions lined up for us to answer, and I think it's going to be just a round robin, who wants to answer, and what's interesting to you or what do you know about. And it's unfair to say we probably all know something about all of these, but anyway, it's going to be fun. I love crossover events.
Yeah, we're gonna have to do more of these. These are a lot of fun, and
Yeah.
we put out a call for questions from folks, and in the past we've done some a patient sort of advocacy series type thing, just sort of a patient education. Mississippi did one for us on Medicare Advantage plans, which was really good. Got to speak to my mother about that, so a lot of fun. And so this one was, all right, if you had a question that you want to ask a bunch of healthcare experts, which is fun to call yourself that. I'm Seth Johnson, healthcare expert. So we just asked that. We put that question out on social media channels and through a few other things, and we got a few interesting questions. And I think this will be kind of fun because these are questions that I've heard several times from family members, friends, and just general patient population back when I was on the provider side. So let's jump in with the first one. John F. asked, I just received an EOB approval letter for a procedure I had in August, which I thought was pre-approved, or at least the provider was listed on my insurance company's directory. Why did it take them almost 8 months to pay the provider?
I will take that one. That is a great question. And there are lots of answers as to why it could take that long. But I'll just kind of talk through kind of the process of getting your claim out to the provider and then what happens there. So when you have your procedures done, hospitals have what they call a standard delay, which is typically anywhere from 3 to 7 days. And what that means is that gives time for all of the charges to be put in. It gives time for coding to get encounter coded and for the claim to drop for the billers to work on. And the reason for that is to make sure that all of the charges are captured appropriately and that all of the documentation is there so the record or encounter can be coded. So when it drops to coding, it goes into the billing queues. Well, sometimes there may be edits or things that come back in our electronic health record that we need to correct a code or put a modifier or something like that got missed somewhere in the process. Well, then after billers get it, they push it out to the payer. Well, the payer may have an edit in place that maybe they require a specific modifier, or they require something specific to be on the claim. For instance, authorization number or something like that may have gotten left off of the claim. And when I say like fields on the claim, these claims have 100 fields on them. That sometimes you populate information and sometimes you don't. So it's very easy to leave something off. So that goes to the payer, and the payer usually takes anywhere from 2 to 3 weeks before they ever pay the claim. If there's an issue, the payer will send it back to the provider. It will fall into a work queue, and then somebody has to go and work that edit. But it may be several weeks before they ever get a chance to work that edit because they're working other claims that need to be pushed out the door. And then when the payer gets it back, the payer may have an edit that you got to research. So what the payer's telling me is wrong with it may not be actually what's wrong with it. It may be something else. So they may tell me that there's a prior authorization issue when it's really not a prior authorization issue. And then the provider has to try to figure out, okay, what does the payer really want? So by the time all of this transpires and you get an actual clean claim to the payer, and then they usually don't pay for 2, 3, sometimes 4 weeks, then that comes back in. So that's why it can take so long. And people will need to understand that it can be very complicated getting a denial overturned to go back to the payer, because there's lots of different reasons that can happen. And sometimes it takes a long time. If the provider is backlogged, so they have a backlog in coding, and things are 3-4 weeks before it's ever coded, that's how the time adds up, and it takes so long to get things.
And that process is being amplified by thousands and thousands of patients encounters across that provider, depending on the size, right?
Yeah, I have a small rural clinic. They see 60,000 patients a year, and that's a small rural clinic. So it's a lot. It can be a lot.
Yeah, one of the things you said, Lorie, that I wanted to kind of highlight a little bit was when we finally get that claim sent out, right? The first time we send it to the payer is maybe the most important time, even if it comes back with edits and denials or, research you have to do, because as you said, if you're behind filing claims, then some of these claims could end up hitting what we call timely filing. And so you've got to get it filed as soon as possible so that it doesn't hit timely filing, because what timely filing means is simply if you don't do this file a claim within X number of days after an encounter, then you can't file it. You just have to write it off. You can't bill the patient for it. You can't bill the insurance company for it. It just has to go as money you write off, as if you did the services for free. So that's kind of one of the reasons the things that land in the work queue don't get priority also, is because that you got to get those initial claims out the door to the payer for sure. One of the things too, I love the way that this question is posed, because it shows how complex our healthcare system is. Because the question is, I had a procedure done that I thought was pre-approved, or at least the provider was listed on my insurance company's directory, meaning it was an in-network provider. Just because you see an in-network provider does not mean that the procedure that you had done was pre-approved. It just means this provider is contracted with that health plan to do services for a particular contracted rate. That procedure that you have done has its own set of data. It's got a code. It's got a revenue code or a place of service requirement. It's got a CPT code or a HIPcast code that says this is a procedure you're having done. And no matter which contracted provider that is, your member benefits will determine if you have to have a prior authorization for that. So that's two complex pieces of the same pie here, because you've got the contracted provider who's contracted to provide certain services in certain settings. Then you've got your member coverage that says, because I work for this employer, they want to pay for all of these with no prior auth, but these 3 procedures they require a prior auth for. So those are two really complex pieces in the same process.
That's pretty fascinating. Go ahead, Kristen.
Yeah. Well, Lorie brought up, that you had a rural health clinic that saw 60,000 patients a year. Sometimes those hospitals, like the amount that they're billing runs into the millions. And so they're trying to make sure that everything is put together in place so that they can bill it effectively. And so patients don't see that back end component of it. I'm frankly thinking that he was doing pretty good in seeing his bill and EOB come through in the time that he did. I just got one a year and 2 months ago, and I was like, oh, nice. I don't even know what we went to the doctor for on that visit, but that was great. So I think there's some components of this that patients just don't see, and don't see that dollar amount either, to know that not only you might have gone in, but there are big cases that they are trying to get pushed out, because those are really, really, really important to get pushed out. Not to say nobody else's are, but
that's
just that, like, those high dollar amounts are really important.
True.
And typically when we get denials and things back, they're going to work those high dollar ones. So if you've got you've got something that was, $200-300, but you've got a $10,000, $15,000 outpatient surgery, you're going to work that high dollar outpatient surgery first. And typically what happens in those cases is then the patient's not responsible for paying the provider if it doesn't get taken care of.
Mm-hmm.
Well, if they're working their denials. We've had clients that I've walked in there and they had stuffed denial letters behind their filing cabinet because the person didn't want anyone to know what was happening.
Goodness.
So not that they should do that or not that they would do that, but there are facilities that have done that. And so it might also be someone coming in and be like, we have to clean this up. And so it does look like it was later, you know, than it should have been.
So what kickstarts that process for the EOB coming from the payer? Because I think there's some confusion there sometimes for patients of, I received an EOB. Is this from my insurance provider? Is this something with the hospital? Just, you know, it's a fun additional question to John, or from John. That's not from John, it's from Seth, but because of John. So what kickstarts the EOB process?
Yeah, the claims adjudication process at the health plan itself. You won't get any kind of So the member of a health insurance company would not receive an EOB from the health insurance company, which, by the way, EOBs only come from health insurance companies. They do not come from physicians or hospitals.
And so Shannon, what does EOB stand for? I
know. Explanation of benefits. EOB, explanation of benefits. So a person who's had medical services will receive an explanation of benefits or an EOB from a health insurance company after the provider, hospital or physician, has filed a claim that the health plan has what we called adjudicated or processed. So it won't be until that processing happens, whether it's denied or paid, it doesn't matter. When that processing happens, that person will get an explanation of benefits from the plan. At the same time, a remittance advice that matches it goes to the physician or the hospital. So remittance advice is the same communication that goes to the hospital or provider that matches the EOB that goes to the patient. Important, Kristen brought up a personal case earlier. After the birth of one of my two grandchildren, probably almost 2 years later, maybe more than 2 years later, my daughter-in-law received a bill from the hospital for the full amount of the delivery services. And she had double health insurance coverage at the time and should have had the deductible only from her primary coverage. Turns out the hospital, for whatever reason, did not file this claim timely. And my daughter-in-law started paying the claim. And she said, I wish I didn't have to pay this. And I said, why are you paying that? What's happening? You had double coverage. What's going on? And she started showing me the information. I said, Hannah, you don't owe any of this. This provider didn't file your claim timely, and they cannot, it is illegal for them to bill you. And if you need me to get on the call with you, to be the voice for you to say that, I'll be happy to. She said, well, they said that I still had to pay it. And I said, no, absolutely not. You do not. And I am happy to be that vocal person for you because I am not afraid of that. But they ended up having to write it off because they let it hit timely filing for whatever reason. So basically, one of my grandchildren was born for free.
Well, that's nice.
It's costing me every cent, but it was born for free.
So let me see if I can recap that in human language.
Okay.
Let's go
in
back
human language,
in human
opposed to blocking or something.
Stuff. Yeah, exactly. So let's go into the EOB question or the EOB statement. So Mississippi described the process from the provider side of when a service is completed. There's a process for the hospital to actually complete the record, code the record, and then move to billing. Once that billing has then been sent to the patient's insurance provider, the insurance provider is going to process that, basically saying we've acknowledged that we've received this this remittance or this charge, right? And then the insurance provider should, at that point, send an EOB to the patient saying, here's everything that was billed to us. Here's everything that we believe we're going to cover as per your plan and your patient responsibilities. And then they're going to send the same or similar back to the provider to say, here's what we're going to cover. Here's what the patient's responsibilities are.
Yes.
I'm going to pause there and make sure that that's
exactly
the
right.
process.
That's exactly what happens.
It sounded very human.
That's very human.
Very human.
You all know I've got to put this into normal people talk because I'm a normal people. That's how we talk. So, all right. So that's very helpful, I think, from a patient's perspective to understand kind of how, one, it's complicated. Two, the provider's doing this across thousands and thousands of patients.
Yes.
The payer's doing this across thousands
Millions.
and thousands and
Millions
millions
of
of
patients.
patients. So it's a very complicated process. So that's why you all of a sudden get this EOB, and then that's why all of a sudden you may get another bill from the hospital at some point after you've received these things. Now, Shannan, what you brought up is very fascinating because patients may not understand. All of a sudden, I did have a service at this provider. Now I've got a bill. I owe this bill. You have to be very careful when you look at that to validate, one, have you received an EOB from your payer? And then look at that bill that your provider sends you and validate that it has been turned into your insurance provider for their portion of it.
Well, and even better than that, or along with that, learn to read that explanation of benefits or that EOB. If your provider billed $10,000 and the health insurance company does whatever it does to process it, and at the end, patient's responsibility, if that patient's responsibility is zero, then you don't owe the provider anything.
Nope.
And if the provider is billing you for that, you need to call them to say, I'm holding an EOB in my hand and my health plan says I owe you nothing. And advocate for yourself because you should not be paying if the health plan says your patient responsibility is zero, you shouldn't be paying. If the health plan says your patient responsibility is $30 and you've paid your $30 copay, then you've paid your $30.
All right, I'm going to keep going rogue here because this is actually really fun. I'm telling you,
I was going to say, before you go rogue, let me explain something a little further about, because y'all mentioned getting a hospital bill. So most hospitals don't send a statement, or a lot of hospitals don't send a statement to the patient until insurance has been completely paid or whatever they're going to do. They don't send it back. So this John that got the EOB 8 months later, he may have never seen a hospital statement until after that hospital was paid. So it could be 8 months. There are some hospitals that will send a statement that will have the full total on there, and it will say your insurance has been filed. That's not really a bill. That's just telling you
it usually
this is how much it was.
This is not a bill,
this
right?
is not a bill.
Okay.
Yeah. So you will see that, and I know a lot of people will get all upset, even though it says, Shannan, this is not a bill.
This is not a bill.
You know, they're calling upset. So that you're just getting a statement saying, hey, this is how much it was, and we filed your insurance, and we're just waiting on them.
I mean, this is fantastic information. So you mentioned deductible. Let me ask a question on that before I go back to my rogue question that I've got to remember that I had. So, we had several questions that we were going to answer. This is going to be a multi-part series. I can already see from where we're at here. So, deductible. As a patient, and I go into the hospital, first thing at admissions, they say your deductible is $14 billion. How would you like to pay that today? I always tell folks, never pay your deductible at the beginning. Wait until after it's billed and just lump it into your total bill. Again, this is not professional advice. I'm just asking from that perspective, what do you guys think from a deductible perspective? Should the patient be paying that up front, or should they wait until they see what their insurance pays and then put that in the total bill?
Boy, there's a lot of answers to that.
So, from a provider, let me answer that question from a provider. If it is really the first of the year and you've not met that deductible, you really should pay that deductible up front if you know that it's out there. Now, a lot of people have large deductibles now, and they can't afford to pay all of it. So when you're going to have a procedure, you should talk to the financial navigators in that facility and work out a payment plan that you can afford to pay that. So you can pay it over time, because not only do they want your deductible, they want your 20% up front too. And if you're going in for something like a surgery, that can be several hundreds or thousands of dollars. So hospitals look favorably on people that make a good faith effort to, okay, I'm going to sign this payment plan and we're going to pay it over time. So you should pay that if you know you're responsible for it. Now, if it is April or May and you know you've met your deductible, I would push back on having to pay that deductible up front, because you've already met it and you know that.
Shannan, Kristen, anything to add there?
Yeah. So a few things. I agree with Lorie. I also think whether it's elective surgery versus emergency surgery makes a huge difference.
Yeah.
Elective surgery, you know that you're going to have it, you're planning for it, you should be paying toward your deductible, even if you can't pay it all at once. Like Lorie said, get with the financial navigator that most hospitals and physicians' offices can help you get to. They usually have those services, but make a payment plan. If it's an emergency surgery, don't put that extra pressure on yourself to think, I've got to pay my $5,000 family deductible or my $3,000 deductible for my individual self in order to keep from dying of a heart attack. Like, don't worry about that. Emergencies are not asking you for your dollars. So just think about
put the
elective
credit card
surgery
slide machine on your chest when they're about to crack it, right? They're going to put that
right. They're not going to do that to you, right? Now, if you're in the emergency room, it's going to be very different. In fact, it's illegal for them to try to get your payment, I think, from a Primo Perspective or EMTALA. So I think that it's important to note, we're not saying don't go to the doctor. Okay. We're saying go. But if your procedures that you're going to have are elective, start planning for them as soon as you know they're going to have to be there, and then just make the good faith effort. So I think that's important. But I will say there are rare cases where the timely filing, the provider doesn't file the claim, and anything you paid toward your deductible, it's going to be a question mark about whether that gets applied to your deductible per your insurance company, or did you just hand $3,000 to that hospital and that's it?
Yeah.
So there's a question there. Lorie, what would happen with that? If I paid my deductible and then the provider didn't file until timely filing had passed, and the health plan says we're not paying any of this, would the health plan honor my $3,000? I don't think they would.
No.
Yeah.
I don't think the hospital is going to just magically send you a check.
They're definitely not magically paying you back.
So sometimes they will.
Sometimes it's not because they want to keep your money. It's just because there's not really a process in place that is normal.
Healthcare is not necessarily the one where you get a big credit at the beginning of a procedure to be able to go back and change that billing.
Typically, what we would do as a provider, if you have any other open accounts, we would take that money you've paid us and put it on those open balances that you've had to close some of those out.
Yeah.
That happens anytime a hospital owes you money back. If you've got open accounts, they're going to apply it to those open accounts and try to close those. Yeah.
Kristen, what do you think about the deductible?
Well, so I think that brings up a good point that a lot of patients that I've discussed this with don't really understand, is that if you are having an elective surgery, I have talked to a handful that have said, oh, well, new year, new me. And they decide to get all of their elective surgeries out of the way at the beginning, not realizing that if you were to push that maybe until, the second half of the year, you might have already met so much of that that you don't need to tap into it as much. It's a surgery that they need to have, but it's not imminent, it's not emergent. Right. So they can push it back, and that does allow them the opportunity to not pay as much because it does go to the insurance company. But it's interesting to hear how many patients I have talked to. They're like, oh, but no, I just want to get it out of the way. That's why we have so many surgeries that happen in December. Everybody's cramming them in. Doctors doing them, So I think that that's a good point to note, is that patients don't realize that this is a year-long thing. So don't go into it with your New Year's resolutions going to be that you're going to pay out as much as you possibly
can. I have a funny about that, about the December. I had my hysterectomy on December the 31st, come
Oh,
hell
Lord.
or high water. I
It
was
was
having it.
happening.
And it was during COVID, and you could not spend the night
Oh, my
overnight. So I had a
gosh.
hysterectomy and
Oh,
went
my
home
goodness
the
gracious.
same
Poor
day because
Sam.
I was adamant. I was
Poor Sam.
not going to have to pay
Poor
that
Sam.
deductible for the next day. No. So,
Good
yeah,
thing
patients
Sam's a
do crazy.
nurse.
He is a nurse. He took
I
really
know.
good
Good
care
thing
of
he's a
me.
good nurse.
But look, I was telling my doctor, I was like, "You're doing this, and you're going to do it before the end of the year." And like I said, it had to be done, and you had to go home the same day. But that's what happened because I was not paying that deductible again.
Uh-huh.
It's a good
Yeah.
reminder to the patients, because the part of what we're doing this series on is for the patient population.
Mm-hmm.
You have rights as a patient. Don't feel
Yes.
like healthcare is a pay to play environment.
Yeah.
You don't have to walk in there and hand over cash to get treatment. There are
Yeah.
so many rules in place. Now, is a hospital, I don't want to say incentivized, do they want you to pay that deductible and 20% up front? Absolutely, because
Yes.
They need you
cash
to.
flow
They
is
need
very
you to if
hard.
you can. Yeah. They
Cash
need
flow
you
is
to.
very hard in healthcare. It
Mhm.
truly is. But don't go in thinking that I can't do this procedure. I'm not going to go to the doctor because of this.
Yeah.
Could just reach
Right.
out to the provider and say, I can't put $2,000 up right now, but
Yeah.
I need to be seen. Okay, well then let's make a plan. Providers will make a plan for that.
Yes.
So if you hear anything from this, know that one, yes, it's complicated, but two, the provider will work with you on the finances side to spread that out over time, to work with you on getting that done. Make sure you're seeking care and taking care of yourself.
I will say
Seth-
this.
Oh, go ahead, Lorie.
Sorry, hold on. Okay. So that leads us to for-profit facilities and corporate entities that are running hospitals versus your local rural hospital or a nonprofit hospital. Your nonprofit hospitals, and those are going to be like your county-owned hospitals, your university medical center hospitals, your rural community hospital. They're in it for patients, and they're going to be more apt to set those payment plans up than a corporate hospital. A lot of times you may get a lot of pushback from a corporate facility or for-profit organization of wanting that money up front before they would do those procedures. So that's something you need to look at too. If you're struggling financially and you want to have this procedure, you got to have this procedure, your usual hospital may be a for-profit, and they're going to push back a little harder than those community hospitals are going to.
Yeah, cash is
That's
king.
true.
Cash is very hard in healthcare
Yep.
because the expenses are so
It
high.
is.
The cash comes in later after the procedure. So whether it's not for profit or for profit, going into it as an informed consumer of healthcare, that all right, that cash flow is a challenge for them. That's why there's certain differences between the differences of providers. It helps you make an informed decision and work with your provider. Kristen, you had something to add there?
Yep.
Oh, I was just going to say, thinking about it from the patient side, we hear them, like, I hear you say provider. I know exactly who you're talking about. They might be thinking about their physician. And so making a plan with their physician isn't always the process when it's in the hospital. I've also had, this is terrible to say, but I've also had, patients or even family members say, well, why would I pay this? Because my doctor was terrible. And they think that they're really sticking it to the provider, but they're actually sticking it to the organization, the hospital and the facility itself that's trying to serve the community. So I think there's a big difference there between finding a plan and a path with the facility versus finding a plan and a path with the provider. Because if the provider is actually, your doctor and you're going to a small doctor's office, that's handled very differently still. And so I just wanted to clarify for viewers that they know that providers can mean the facility that's down the road from you, but it can also mean the actual doctor that's treating you.
Yeah. And I'm going to continue to pull the thread that you just started to unravel, Kristen, because what one question has led us to a million answers. You will probably, as a member of a health insurance company, whether it's Medicare or a commercial product or Medicaid, it does not matter. You will probably get an explanation of benefits or an EOB from multiple providers or provider types. So, in the case of a hospital, you're going to get an EOB and a bill eventually, probably a statement of some sort from the hospital. You may also get a separate one from a treating physician.
Mm-hmm.
And then if you have surgery, you're going to get one from a surgeon, a surgical physician. You will also get one from an anesthesiology group.
Mm-hmm.
And if you had imaging, you may get one from a radiology group.
And if you come through
Because
the
the
ER, you're
radiology
going to get the ER.
The ER, that's right, the ER
Yeah.
doc. So you're
And
talking
ambulance
about,
service, if you're on a
and if you went by
non-ambulance
ambulance,
service.
if you went by ambulance, you're in trouble. It's just ambulance claims are some of the hardest to process, but you're going to get, and it's not like, I think some people think that you go to the hospital and there's going to be one bill that encompasses all of that. And I would love it if that were true, that the hospital was the benefactor of the entire claim and distributed kind of like, never mind, I'm not going to say that on this. This is for patients. But if it were just collected by the hospital and distributed appropriately across those entities, then you would be able as a patient to get one EOB, one explanation of benefits, one statement from the hospital that had everybody's stuff on it, and it would simplify it for the patients. But that's just not how it works.
Not how it works.
There are we named at least a half a dozen people or organizations involved in your care.
Yeah, there's 7 companies there in that scenario that helped provide care throughout that process. So yeah, all 7 are going to have their billing process, their conversation with your insurance provider, and then their conversation back with you on what remains from that. And that's it's not a unified health system in the U.S. It is different services that are providing the overall picture for your care. And that's why you're getting these multiple bills, multiple communications on a single instance of care.
And each one of those entities are contracted separately with the health insurance companies.
They are. I do want to throw something out because I talked about the difference between rural and nonprofit versus for-profit. Hospitals that are county owned or government owned, they have things called self-pay discounts. And there are rules set up by the government for that. So you can actually, even if you have insurance and you want to have something performed at a self-pay, you can get an adjustment. They will give you an AGB adjustment, an average adjustment that we get. A lot of times they will bill you at Medicare's rate, which is lower than
significantly
commercial
sometimes
payer. And sometimes you can get an additional discount if you pay all of it at one time. So there are instances when it is cheaper to be a self-pay patient and you can pay all of it at one time than it is to file it through your insurance.
True.
And there again, hospitals love cash up front. So they're happy a lot of times when patients do those kind of arrangements.
Yeah, they don't have to chase that cash. It costs them nothing to get that money at that point, right? Every time they have to send out a statement to get a new bill paid, it costs them money to process that and send that out. So
and you can negotiate.
Yeah.
I negotiated with one of my wife's bills. It was a significant amount of money, and I called them as soon as I got the bill, and I said, "Hey, I'll pay you X percentage amount today. I'll write you a check." And they said no. And I said, "Okay, put me on a payment plan. $10 a month is what I can do. And no, I'm not signing up for e-statements. I want a bill sent to the house." And they would send me a color printed page bill to the house once a month for $10. And I would handwrite my American Express on the form, put it in the mail, and I'd mail it back to them. Did that for 6 months, called back and said, "You ready to negotiate?" And they negotiated, and we were able to pay that bill. So you do have rights and power as a patient going into this. So
True.
We came into this crossover episode with 4 questions. We answered 1. So this means this is going to be a series going forward because this was incredibly powerful. I think this is going to be great information for the patient population. For our audience that are health information professionals, we understand that most of you probably know all of this, but this is an opportunity to share this with your family and friends that may just want to know why this is so dang complicated in healthcare.
Seth, I was just going to say real quick, a lot of people that work in healthcare do not know this. You've got to specifically be working in revenue cycle to understand this.
That's very, very true. That's a valid point. So
I think it's true.
Well, this was great.
our peers, right, our health information professionals know most of this.
Should, right?
Should know most of this. But Lori's right. A physician doesn't know how to walk through unless their revenue cycle or, something like that.
Yeah, that's a very valid
they don't
point.
know for sure. So
even the healthcare workers don't truly understand all the processes throughout. So, well, this has been a lot of fun. So we're going to save the next questions for the next round because we're going to do this again. These crossover episodes. I had a blast with this. Love seeing you guys. So Shannan, until next time, my friend.
See you next time, buddy.